Okay, good morning, everyone. This lecture will, is this it? No, right. Okay, this lecture is going to focus mostly on hemorrhagic shock, which is the most common type of shock we see in trauma, although I will take a few minutes and discuss the other, the other types of shock too. So we want to talk about the definition of hemorrhagic shock, obviously the most common causes, um, signs and symptoms, how do we get early control of hemorrhage, and some of that's changed in the last 10 to 15 years, as we'll talk about, and then how we treat and manage these patients. Most important thing I can say about shock is down in the red, down there. It's inadequate tissue perfusion. It is not related to a low blood pressure. So that's one of the signs, but I hope by the end of the talk today, we can understand that if we can find some of the more subtle signs of inadequate tissue perfusion, we don't wait until the patient is totally decompensated before we can intervene and act. So again, clinically, we manifest by hemodynamic disturbances. One of the late signs of that is a low blood pressure, but we hope to find some of the earlier signs. Just as a quick review, for an ideal 70-kilogram patient, and if you just listen to Dr. LePage's last thing, you'll find that probably 70 kilograms would be considered light at this point in the United States. But a 70-kilogram patient has about 5 liters of blood. So the best way to figure that out is for adults, it's about 70 cc's per kilo. So for an adult, that would be 4,900 cc's. We round it off to make the math easier, and we come up with about 5 liters. The heart as a pump is volume responsive. And what does that mean? In a normal person, what is your cardiac output? It's equal to your cardiac input. That seems like a who's buried in Grant's tomb kind of question, but think about this. If we had a young, healthy person, put a central line in him or her, and then gave them 3 liters of fluid, you wouldn't go into heart failure. As the right heart saw the increased amount of fluid, we'll talk about preload, et cetera, your heart would continue to beat that out. So the input would equal the output. So it's very volume responsive, and we'll talk a little more about that as we go along and talk about resuscitation. So we want to provide hemodynamic support regardless of the cause of shock. So we don't need to wait and identify the cause as working through the algorithm. We want to start to provide hemodynamic support. In traumas, frequently that's fluid and frequently that's blood products. So again, shock is a loss of, hemorrhagic shock is a loss of the normal circulatory volume, blood volume. So in adults, blood volume is about 7% of ideal body weight. Children, it's a little bit higher, so always keep that in mind with kids. There are 4 classes of shock. There really are no absolute values as you go from class 1 to class 2, but we'll talk about the signs and symptoms and clinical findings. You'll identify those in those, which would tell you that you're farther down the pathway in terms of shock. One more thing you'll find is our treatment and how quickly we work is determined by the patient's response to intervention. So we'll talk about some people who get a little bit of fluid and they do well. We have some people who will respond to fluid and then deteriorate again. And then we have some people who, despite fluid and resuscitation, don't get better. And then those patients, obviously, they're considerably more sick. Just as a review, historically, trauma had a trimodal death distribution. So a large number of people you'll see in that little yellow arch on the left side, 60%. Those are patients that die of massive brain injury or massive hemorrhage. Many of those historically died at the scene. They didn't make it to the hospital. That next 30%, many of those died of subdural or epidural hematomas or ongoing hemorrhage that we weren't able to control. And when you look at the green wave there, which was the 10%, those tend to be patients who we get resuscitated, but historically died of multi-system organ failure. More recently, however, as we've looked at this, we see that it's really a bimodal trauma death distribution. So in that early 60%, we still have people who have non-survivable injuries, and this includes, by the way, people that are dead at the scene. So this includes massive head trauma. massive hemorrhage. With the advent of organized EMS systems, the realization that scoop and run is probably better than is a better way to manage a trauma patient than we would with a cardiac arrest, where we stay on the scene and give medical interventions, et cetera, and rapid transport times, use of aeromedical services in remote areas. We get a lot of those patients to the hospital. That 30% sometimes still dies of uncontrolled hemorrhage. But again, the loss of that second mode is largely due to advances in pre-hospital care. That second mode, which is 10% between 1 and 4 weeks, that's the group that, as I mentioned earlier, used to die of multi-system organ failure. Probably that proportion now are patients who get support withdrawn, who have significant head injuries and are not expected to recover, and support is withdrawn, although multi-system organ failure would still be included in that group as well. A few things to remember when we talk about cardiac output. Your cardiac output is your heart rate times your stroke volume. So again, it's beats per minute, heart rate. Stroke volume is volumes per minute, and that gives you liters per minute. Cardiac output has 3 contributing factors. One is your preload, the next one is myocardial contractility, and the third one is afterload. We frequently think of preload as a volume, and although that is a contributing thing, it's not 100% volume, but if we want to improve preload, we usually give fluids, which will either be crystalloid or blood product. Myocardial contractility is how your heart functions, how well it's beating. Back in the late 80s, when I was a paramedic, most of trauma patients were very young, so we never had to worry about myocardial contractility. They all had young, healthy hearts. Nowadays, with the aging of the population, we'll find out that there's a large number of patients we have who are elderly, and regardless of how you define that, whether you say greater than 55, greater than 65, we have a large number of elderly patients who come in with significant cardiac issues, and so that may be impacted just from pre-existing medical conditions. Afterload is basically, think of this as the hill that the heart has to work when it pumps out blood, which goes to your peripheral vascular resistance as well. So let me just take a moment and talk about the types of shock. There's 4 types of shock: hypovolemic, cardiogenic, obstructive, and distributive. All types of shock fit into one of those 4 categories. So when we talk about hypovolemic, let's think about preload. It's a decrease in preload. In trauma, that's frequently hemorrhagic shock, but just remember a number of other things. Dehydration can be you're running a marathon and you're not taking enough fluids. It could be that elderly person that falls down the stairs and lays at the bottom of the stairs for a day or so before someone finds him and hasn't taken fluid for 2 days before they get found. It could be diarrhea, emesis, excessive sweating, again, in athletic events, or when you're sweating more than you're able to take in. So think of hypovolemic as a primary problem of preload as the short answer. Cardiogenic, think about this as an intrinsic impact on myocardial contractility. So this is intrinsic pump failure. Best way to think of this is a myocardial infarction, where you have muscle damage to the heart, or a non-perfusing cardiac rhythm. Those are probably the 2 quickest examples and best examples that you'll see most often. Obstructive shock, think about this as an intrinsic impact on myocardial contractility. 3 big ones there are the tension pneumothorax, pericardial tamponade, and massive pulmonary embolus. So in the trauma setting, we see tension pneumothorax and pericardial tamponade. So one of the things we quickly do when we assess a patient is we want to make sure that that the trachea is midline, because if it's deviated, we want to listen to the lungs quickly and identify if there's a tension pneumothorax. While we will identify this also on X-ray, a tension pneumothorax, really we don't want to identify that on chest X-ray, because that means we've missed the clinical signs of this. Pericardial tamponade is another one, frequently related to some penetrating torso trauma or chest trauma. When you see, if you're in the trauma bay, when we do this, one of the first things we do when we do the FAST exam is one of the first windows we look at is the pericardial window to see if there's any fluid there. Massive pulmonary embolus, not common in the acute trauma setting, but certainly it can occur in our patients if they've been in the hospital for a while. If you work in the cardiac ICU, you may see this as well, but a massive pulmonary embolus that really impacts the right heart's ability to contractile function just because of the back pressure and the right heart failure you'll suddenly get. Distributive shock, think about this as an afterload problem. So you lose your vascular tone for one reason or another. Neurogenic shock from a cervical or high thoracic spinal cord injury is the one we see in trauma. But again, if you're in the emergency department, anaphylactic shock. If you're in the ED or now even in the ICU, septic shock will be another one where your peripheral vascular resistance is negatively impacted. A couple hormones in shock. We talked about fluids and preload, but again, epinephrine and norepinephrine, think about this as your the fight portion of your fight or flight response. That'll increase your heart rate and contractility. It'll improve your peripheral vascular resistance. And again, these are the hormones that increase your pulse pressure. In other words, while your systolic blood pressure stays the same, your diastolic blood pressure increases because your vascular tone is increased. So that's one of the early signs even before your systolic blood pressure drops. The renin-angiotensin axis gives you the aldosterone and antidiuretic hormone. This is your body's way of saying as your volume goes down, we have to conserve water and sodium. It contributes to vasoconstriction, and it will increase your blood volume and blood pressure. Remember, this is why your urine output starts to decrease too. So stages of shock, we'll talk about initial shock. These are the early signs. Then where your body tolerates it fairly well. When you get to compensatory shock, that's when your body starts to make some compensatory factors. The hormones that I just talked about will start to be exhibited. You'll start to get a higher diastolic pressure or a reduced pulse pressure. You may get a little anxious. Certain organs are now starting to get shut down. So you get less blood supply to your skin, and so you get cold and clammy and a little bit diaphoretic. This is, again, before your blood pressure changes. As the progressive shock starts to set in, you get to the point where now your blood pressure is declining. And refractory shock is what we don't want to see. That's where, despite intervention, it's basically decompensated and you're not coming back from that. So one of the things we want to do as trauma surgeons is make sure a patient never gets to refractory shock. So just as some background, trauma was one of the first disease processes that was considered a time-sensitive process. That's why we have trauma centers. It's why we have pre-arrival activation, and it's why we talk about how we have to get things done. This is what kind of spurs the concept of the golden hour. And while it may not be a literal 60 minutes, it's time sensitive. It doesn't matter that eventually we get to the operating room to take out a ruptured spleen. It matters that we do that in a time when, even after we get it out, the patient is not in such a decompensated fashion that they don't survive. Nowadays, you'll hear, if you've been here in the hospital, you hear about sepsis alerts and stroke alerts and STEMI alerts. But again, trauma was the first disease process where we kind of understood the need to intervene quickly to avoid us getting down this pathway where we can't resuscitate a patient at the final point when they decompensate. But what injuries are prone to hemorrhage? Obviously, large vascular injuries. We think about the aorta and the cava. In trauma, we see splenic and liver injuries a lot. So the solid organs, very well perfused organs, and therefore, if they get injured, likely to bleed. From an orthopedic point of view, pelvic fractures and femur fractures, certainly we can lose a lot of blood there. So we want to quickly rule out blood loss. So you'll see in the trauma bay, we'll get a quick chest x-ray and a FACS exam, which will look at the pericardium. It will also, with the extended FAST or the EFAST, we can also quickly look to see if there's a pneumothorax with the sliding of the pleura. For the abdomen, and I'll talk about this in the next lecture, but abdomen is a very sometimes challenging area to find if there's a problem. Blood is not a peritoneal irritant particularly. So if you have 100 patients with blood in their abdomen, 50 may have a benign abdomen. So about half have a benign abdomen. So we can't use an exam in itself to identify if there's intra-abdominal hemorrhage. So again, the FACS scan is very useful for that. For the pelvis, evaluation of the pelvis, obviously a clinical exam. If they have tenderness or swelling or ecchymosis in the perineal region, we obviously worry about a fracture. We will frequently get an x-ray because if there's an open book fracture, we can place a binder. And femur, usually, except for hip, isolated hip or femoral neck fractures, which don't tend to bleed as much, mid-shaft femur fractures and distal femur fractures, which are the type of femur fracture that bleeds, usually you can see those by clinical examination and or x-ray. So we want to get those films quickly if we have to, if they're unstable and we're trying to identify the location of hemorrhage. Obviously, one of the situations we have is we want to know if there's blood in the abdomen, we want to go right to the operating room and operate. We don't stop through the CT scan to do that. But certainly if there's a pelvic fracture and femur fractures, we don't want to run to the operating room and open up the abdomen to find out that it's a pelvic fracture, which is managed quite a bit differently. Again, just as a reminder, humerus can lose about 750 cc's of blood per humerus, tibia about the same, femur about 1,500 cc's of femur. So bilateral femur fractures, you're at 3 liters. Pelvis can get 3 liters or more just because there's a larger preperitoneal and retroperitoneal space to bleed in. One of the challenges we also get with fractures is cytokine release. That's associated with soft tissue trauma and bony trauma. As the cytokines release, it increases permeability, so you get some capillary leak, and this may actually magnify the fluid losses that you have from the initial injury. So what are some of the confounding factors in hemorrhage response? Well, patient age. Few things to think about. If you have a young, healthy athlete, they may not get tachycardic. They may have very good reserve right away. If you have an elderly patient on beta blockers or calcium channel blockers, they also may not get tachycardic. Unfortunately, if your patient is either concussed or has a head injury, they may not be able to answer those questions. And sadly, there are a large number of patients we run into who are on multiple medications and don't know any of the meds they're on or why they're on them. So again, lack of patient knowledge about their conditions can be a challenge as well because they may not have that information. So pre-existing disease or medications, obviously the severity, if someone's got multiple traumatic injuries, we've got to quickly identify those and determine an order of management for those. In the pre-hospital setting, you don't need to identify all the injuries. You want to quickly immobilize deformed limbs and get them to the hospital while maintaining cervical spine control, getting access and oxygenation, and following the ABCs en route. Access to care can be a challenge. We're blessed in Fort Wayne to have 2 adult trauma centers. There are some rural areas in the country where you may be several hours by ground to get to a hospital, no less a trauma center. So that can be challenging. We talk more about the austere environment in the military or in a situation where there's a mass shooting or a mass casualty event, and you may, even though maybe close to a trauma center, it may take a while to get out of that environment safely. Duration of shock is a challenge. Obviously, as I mentioned earlier, if you go, there comes a point when shock is not resuscitatable. And so if someone's had shock for a very long time, even if we ultimately do the right thing, we may not be able to resuscitate the patient. Pre-hospital fluid, how much to give, we'll talk about that a little further. And obviously the presence of hypothermia confounds things. Cold kills trauma patients. Now I know that's not what is the case for a post-cardiac arrest patient, but we'll talk about the pathway and the challenges of hypothermia and what it does in terms of the clotting cascade and resuscitatability to patients. Here are the floor classes of shock, whether you've been in EMT training, paramedic school, nursing school. This is from the ATLS course, the Advanced Trauma Life Support course. Best way to remember this is there's 4 classes of shock, add a 5 to each one. So class 1 shock is about 15% blood loss. Class 2 shock is about 25% blood loss. Class 3 shock is about 35% blood loss, and Class 4 is greater than 45%. So just remember as you go along with this, think Class 1 shock, that means you go to the blood bank and you donate a unit of blood. Heart rate never goes up. Your blood pressure stays absolutely normal. Your pulse pressure stays normal. Your respiratory rate doesn't change. Your urine output's fine. And either you're normal or could be slightly anxious. Again, most of the maintenance of cardiac output in this case is due to your increase in your stroke volume. So your heart rate doesn't need to go up. When you lose about 15% or more, so that's about 750 to 1500 cc's of blood loss, now your heart rate can start to get up above 100. Blood pressure is still normal, but here's where your pulse pressure starts to decrease. So remember I said pulse pressure decreases, your systolic is normal, but your diastolic elevates. So that's what causes the decrease. Now, just remember one more thing. When you feel your pulse, what are you actually feeling? You're feeling your pulse pressure. It's the difference between the systolic and the diastolic pressure. So as your pulse pressure decreases because your diastolic is rising, what happens to your pulse? It's what we describe as thready. It's not the bounding pulse like we would see in otherwise a normal patient who's not in shock. Respiratory rate can start to go up here. Urine output can go down, but again, you wouldn't identify it in a pre-hospital field or usually early in the trauma setting because if we put a Foley in, it takes another hour to realize your urine output's down. These patients may be mildly anxious, and more importantly, now your body started to compensate. So now what's going to happen is you're going to get pale, cool, and diaphoretic. So when I hear someone's coming in, they're pale, cool, and diaphoretic, I'm always thinking shock, even though the blood pressure is fine. Can we get someone ask a question?
Go ahead with your question.
Juan, did you have a question? You're on mute. Okay. Juan, if you have a question, if you can type it in the comment box, I can answer it then. Okay, in the meantime, class 3 shock then, now we're losing about a third of our blood volume, 35%. So now we're going to get significantly more tachycardic. At this point, the blood pressure, the systolic blood pressure starts to drop. Now your pulse pressure is decreased because your systolic's starting to drop. Your respiratory is increased. Your urine output on an hourly basis starts to decline significantly. And now you're also anxious and confused. Now, as I'm talking about all of these mental status changes, just remember someone who's been in a bad car accident is going to be anxious anyway because they've just been through a traumatic event, or someone who's just been shot is going to be anxious anyway. Don't write off their anxiety or their mental state to having just experienced a traumatic event. Always think about either a head injury or early stages of shock. Finally, class 4 shock, that means you've lost 40% of your blood volume. Now your heart is significantly tachycardic because you're trying to maintain your cardiac output. Just remember your stroke volume's down because your preload is down. Your blood pressure is now going down. Your pulse pressure is decreasing. Your respiratory rate is high because you're trying to maintain oxygen delivery. At this point, urine output may be negligible. Now you start to get confused or lethargic. So again, also consider this. This is very advanced stage of shock. These people are going to die if we don't intervene quickly. Another thing to remember, they've just been in a car accident. You may smell alcohol in their breath. Alcohol is not predictive against shock or head injury, so please don't write off their CNS response, their neuro response to alcohol or substance abuse. Always presume it's either a head injury or the late response of shock until you prove otherwise. Here's the oxygen dissociation curve. I'll show you this. As that curve shifts to the right, and it looks, I don't know if you can see it well there, but as the curve shifts to the right, which is the red column, we'll talk about what the responses are to that. So think about the shift to the right. When the curve shifts to the right, that means your hemoglobin has a lower affinity for oxygen. That means your hemoglobin and your red blood cells are releasing more oxygen at the tissue than they would ordinarily. When it shifts to the left, that means you have a higher affinity for oxygen that's bound to hemoglobin, and your red cells hold on to it. They don't unload it at the tissues like they ought. So let's look at a few things which shift to the right and allow more oxygen to unload. One is acidosis. So as you go into shock and get a lactic and a metabolic acidosis, one of your compensatory mechanisms is that you're unloading more oxygen at the tissues. And remember, we said shock was inadequate tissue perfusion. So your body is trying to compensate for that. As your CO2 goes up, because you're not ventilating as well, that also gives you the acidosis as well, a respiratory acidosis. Your body compensates by unloading oxygen. That would also be a hypermetabolic situation. So if you're in a prolonged, let's say a marathon, you're producing more CO2 in your tissues, so your body's response is unloading more oxygen. And your temperature increase, okay, as if you had a fever, also allows oxygen to unload. So let's think about a few things here. Suppose I treat my acidosis before I identify it with some bicarb. I fixed the pH or the number, but I've actually made it harder for the body to unload oxygen at the tissue where it's needed. If I have someone in septic shock and their temperature is elevated, and I give them antipyretics or ice them or try to reduce that, what I've done is I've made it harder for the body to unload oxygen at the tissues that actually need it. So we have to be thoughtful about fixing the underlying pathophysiology as opposed to a particular number on a lab test or on one of the vital signs. Let's look at shifts to the left. So what keeps oxygen from unloading at the tissues where we need it? Well, obviously temperature going down, and that's why, just remember I said cold kills a trauma patient. This is one reason why. The other thing to remember is banked blood. And again, 2,3-DPG is what's in every molecule of hemoglobin, and that allows the molecule to deform and actually unload oxygen as well. When you donate blood and it's been in the blood bank for a while, it gets the amount of 2,3-DPG goes down. So banked blood doesn't unload oxygen as well as normal blood, and it takes a while for that to correct once it's given to a patient. So again, it's another reason why while we do give blood, it may not be increasing oxygen delivery, which is actually the oxygen that dumps off at the tissue level, as well as we think. So something to keep in mind. Again, one more thing: normal vital signs do not rule out hypoperfusion or hypovolemic shock. We really want to be able to identify shock before their blood pressure drops. Rough estimates from pulse. Again, these are variable; they're not hard and fast. But carotid pulse usually means the systolic blood pressure is at least 60, radial pulse at least 80, femoral pulse at least 70. And if you have to go down, if you feel the dorsalis pedis or posterior tibial, usually it's about 80. So again, let's say you're out somewhere, someone's in an accident, you don't have your blood pressure cuff or your medic bag or whatever you have with you in the car. That's just a quick estimate of identifying blood pressure based on pulse. So again, systolic blood pressure drops is a late sign to volume loss. So remember, that's class 3 shock, so you've lost about 35% or more of your blood volume. And again, it's decreased based upon the total volume loss. It's not linear. So as you go from a 5% to a 10% to a 15% to a 20% blood loss, your blood pressure doesn't go down slowly. Remember, we've got compensatory mechanisms that I spoke about. Some people will keep a great blood pressure, and when they decompensate, their blood pressure drops, and it's hard to get them back. This happens in children. It can also happen in older adults. So by the time their blood pressure drops, they're really far gone. So again, as I said, in adults, it takes about 30%, 35% of your blood loss. In kids, it's a little bit more. So don't presume because a kid has a good blood pressure that they haven't lost blood. Kids can lose a large amount of blood before they drop. Why is this important? So when you see a kid and, oh, you don't want to hurt them by putting an IV in, just remember it's always harder to put an IV in when they've lost 40% of their blood volume than before they have. So again, when your blood pressure drops, your mortality starts to go up. And again, we really want to make sure we adequately monitor it. First blood pressure should always be manual. I know that's not culture here, but the problem with the automated blood pressure cuffs is it overestimates blood pressure. And when your blood pressure is truly very low, it becomes almost like a random number generator. It really is not accurate. So when the blood pressure is low, strongly consider getting a manual cuff out and check a oscillated blood pressure cuff. And unfortunately, that's not being taught a lot anymore in school, whether it be paramedic school, EMT school, nursing school, or medical school, how to get an oscillated blood pressure. But that's really important in terms of identifying the true estimate of blood pressure. We used to think about blood pressures being below 90 or 100. The mortality actually goes up, and we really are re-looking at this, particularly in the elderly population. Elderly population who have generally some underlying atherosclerotic disease just based on their advanced age. And when they get to a blood pressure of 90 or 100, they can be considerably far gone. So even when the blood pressure is 100, 110, have a very high index to consider that they may be significantly injured. One of the ways to monitor cardiac output is if you look on the EKG monitor, when you see the stroke volume variability, or basically the peak of the R wave or the QRS complex starts to kind of go up and down like a sine wave, like you kind of see there. That's a sign that they may be volume responsive, because it's really related to the stroke volume and the preload. There's a number of ways we can measure this now. One of them is the flow tracker, the Vigileo. These are systems that link up your arterial line and actually can kind of calculate out roughly your cardiac output and whether you would benefit from more fluid or not. Remember, pulse, as we're looking to identify shock, it lacks specificity alone. It can be age dependent. Obviously, if someone's upset after being in an accident, they can be tachycardic. Fever, pain, drugs, all of these can impact your pulse. Just remember, the pulse and character are more reliable. And as I mentioned earlier, as your pulse pressure declines because your diastolic goes up, you can get a more thready pulse. So that's another thing to consider. Any patient who is cool and tachycardic is in shock until proven otherwise. Remember what I said earlier. The one change you'll have in a patient prior to them dropping their blood pressure is their skin become pale, cool, and a little bit diaphoretic. So that's an early sign of shock that you always have to be mindful of. Shock index, you're going to see this out there. I'm trying to think of how to say this. This is like recreating the wheel and getting excited about it. So, a lot of places will talk about shock index and predicting the things. But let's just think about this way. We're worried about shock when your heart rate goes up or when your blood pressure goes down. So your shock index, obviously a higher shock index is more concerning. So as your heart rate goes up, your shock index goes up. As your blood pressure goes down, your shock index goes up, which is just another thing, another fancy way, although you have to use a calculator on this one, to figure out what we've just been talking about for the last 25 minutes. So again, as your shock index continues to go up, it really is a sign of hypovolemia and a marker of injury severity. What's a cold hypoperfusion? That's the state where your oxygen delivery is decreased in the setting of normal physiologic conditions. And again, here, patients don't suddenly deteriorate, we suddenly notice. This is what I talked about in terms of finding the subtle findings of shock. Are they pale, cool, and diaphoretic, even if the blood pressure is normal? If someone's hypertensive, they can lose blood and they'll continue to have a quote unquote normal blood pressure, but they may be doing that. So we always want to be mindful of occult hypoperfusion. We measure that using lactic acid, especially in the hospital, because we want to get people resuscitated for the urgent operations. Let's say it's orthopedic injuries that are not emergent, but we want to make sure we've got them fully resuscitated before they go to the operating room for those things. So how do we assess, initially assess the patient and then decide if we've met our resuscitative endpoint? So earlier on, and we've been talking about this, mentation, are they anxious or are they becoming obtunded? Skin perfusion, are they pale, cool, and diaphoretic? Pulse and pulse quality, blood pressure, pulse pressure, shock index, urine output. All of those are kind of initial assessments of how the patient's doing. Now we've started to resuscitate a patient. How do we know that we've actually completed our job and done the good thing? So pH can be noted off of blood gas, and probably more importantly than the pH is the base deficit, which we'll talk about in a minute, or the serum lactate. Serum lactate is a good number. We have, I think, unfortunately, put such an emphasis on sepsis that sometimes we look at anyone with an elevated serum lactate and think they must be septic, and someone wants to know if we want to do a septic protocol. But lactate's just a measure of increased lactate production in tissues from increased metabolic requirements. Echocardiography, we can do that quickly with a bedside echo during a fast, or up in the ICU, we can do echoes and certainly make sure that at end systole, the ventricles are not collapsed. So one indirect measure of volume status, and we talked about, remember, stroke volume is the amount of blood that's ejected after one contraction, but there should be some left. When we talk about on a formal echo, ejection fraction is usually about 65%. So that means 2/3 of the blood is ejected with systole and 1/3 stays in. If we do an echo and find that at end systole, the ventricles are pretty much collapsed together, that's a sign that they're probably needing a little bit more fluid. We talked about arterial wave analysis, and then there's also near infrared spec to look at specific tissue analysis. That's been used here and there. It really hasn't gained widespread use, just because it's a little bit less sensitive than the others I've mentioned. Urine output is a quick review. Why do we make urine output? Because it's the amount of fluid we need to clear toxins from our body through the kidneys. So with adults, it's a 0.5 cc per kilogram per hour. Let's make the math easy and let's pretend we have that 70-kilogram patient. A 0.5 cc then would be 35 cc's an hour. So when we talk about 30 cc's an hour is adequate for an adult, that's because it's probably the minimal amount of fluid they need to clear toxins from the body. 30 cc's an hour in an 8-hour shift is about 240 cc's. Let's make the math easy and make it 250. So 250 in an 8-hour shift, and then 750 in a day is about what we need. That's kind of the way we do it. Remember, apropos of Dr. LePage's lecture, if someone goes from 200 to 400 pounds, that usually doesn't mean that they need all of that additional. They don't need that much additional fluid because it's really based on a little bit above ideal body weight. Now, why is it higher in children and toddlers and infants? Well, because their ability to filter and concentrate urine is not as good as an adult. So that's why we look for higher volumes in infants and children rather than adults. Just their kidneys haven't matured enough to be able to concentrate the toxins. When we talk about hemodynamic monitoring, I just want to make a few comments here. Central venous pressure is measuring a pressure, not a volume. So there's a real poor relationship between central venous pressure and blood volume. Can they be related? Yes, but there's a lot of other things that increase your central venous pressure. So central venous pressure is a measure of the right ventricular end diastolic pressure, but there's other things besides fluid that can impact this. Intrathoracic pressure, attention pneumothorax, positive pressure from the ventilator. So there's really a poor relationship between that. So we don't usually use central venous pressure as a marker of fluid resuscitation status. This is not only true in trauma patients, it's true in all patients. So using central venous pressure as a measure of fluid status has, it becomes very unreliable. Pulmonary artery catheter. Man, if you're new to healthcare, you probably haven't seen many of these unless you're down in the cardiac ICU, because I think they'll probably use those more. Again, not advocated for hemorrhagic shock. This is a catheter that gets advanced through a cordis, and it advances through the right heart and parks in the pulmonary artery. We can use that, and we can get a measure of the left ventricular and diastolic pressure. We can also get measures of cardiac output as well from these. We used to use these a lot in the 90s, a little bit less in the early 2000s, and probably not much anymore. They do have their benefits in certain categories of patients, but again, it's not something you'll see us putting in the emergency department or early in the resuscitation of a trauma patient. The transthoracic or transesophageal echo. With the echoes now in the ICU, this allows us to give a good bedside evaluation of ventricular function. We can look at volume status based on the what the ventricles look like at end systole. We can measure stroke volume and cardiac output. Obviously, this is dependent on technical expertise. We used to have the echo techs come in and do these. They will do a formal one, and admittedly, probably better than we would as physicians, although there are a number of echo courses for physicians. It is somewhat user dependent, but if you're trying to get a quick assessment of cardiac function when your patient remains hypotensive after you think you've given them enough fluid, this is an excellent tool. Nice thing about it, if it's trauma surgeon or intensivist done, is you can repeat these every hour if you need to. It's not a matter of calling the echo tech back in and then waiting for it to get formally read. So it's an excellent diagnostic tool from a monitoring point of view, because you have to put it on and apply it to the patient. It can be challenging. Also consider if our trauma patients have any chest wall edema, any subcutaneous emphysema from a pneumothorax, it becomes a little bit challenging to do. And then in those cases, we probably need an esophageal echo. Let's talk about some lab tests. How valuable is the hemoglobin and hematocrit in acute blood loss? Well, it's not very good at all. Remember this, when you bleed whole blood, which is the serum specimen as well as the red blood cells. So you can lose 50% of your blood volume. We can draw your labs and you'll have a normal hemoglobin. And hematocrit, because the blood hasn't had time to dilute. So there's a lag time on this. So don't presume that because someone's got a normal hemoglobin or hematocrit when they come into the hospital that they're not bleeding. It just takes a little while. So this is kind of like blood pressure. It takes a while for that to drop. So be mindful of that. So we get the baseline because we want to compare that. We get the labs look okay. We do a workup. We find out they have a ruptured spleen. Now I want to see what their hemoglobin is going forward, because it may impact how we manage that injury. And we'll talk about that more in the next lecture. Again, can be delusional or falsely elevated as well. Someone's been laying at the bottom of the stairs and hasn't had any fluid for a day or two. It's going to look falsely elevated. We give them a little fluid in the hospital, and now it's diluted, and we think their blood hemoglobin's dropping, although it may actually be re-equilibrating to what they were before they fell. Lactate is an indirect measure of oxygen debt. Your body and muscles particularly make lactic acid. Normal values, we talk about normal values be under 1, but really when we worry about a patient, if the lactate level is greater than 2, we start to get concerned. Greater than 5, we really worry about it. Now, not only can oxygen debt raise your lactate, but also there's a number of street substances and drugs that will do it as well. So again, this is a marker how we do things to start with. And we obviously, if your lactate's up, we want it to come down. Particularly when we talked about occult hypoperfusion. So if we have someone who's got a lactate level that's up, and let's say they have some orthopedic fractures that are closed, they're not open, so it's not an emergent that we have to go wash them out. We want to make sure that we fully resuscitate that patient before they go to the operating room. I mentioned the phrase the golden hour, which theoretically was just describing the time-sensitive nature of getting things accomplished in a timely fashion. When we look at this data, if someone goes to the operating room with an elevated lactate for orthopedic injuries, there's some evidence that their mortality can be increased and their complication rate can be increased. Sometimes that's referred to as the silver day. So if you ever hear that, that's what we're kind of worrying about, clearing the occult hypoperfusion and the lactate before they go on for semi-elective or semi-urgent procedures. And again, if we can't clear the lactate within 12 hours, that's predictive of ongoing issues, and the risk of multi-system organ failure goes up. Just remember one thing about lactate: it's cleared and made into acetate in the liver and the kidneys. It takes a while to convert. So lactate, as it gets better, corrects slowly. Base deficit, on the other hand, corrects a little bit more quickly because that's an indicator of your metabolic state as well. Normal range is -3 to +3. We really start getting worried if it's more negative than -5 or -6. Obviously, it's a test we get off the blood gas. Admission base deficit can correlate with blood loss, but there's a number of other things that impact that. And obviously, if it gets worse, we worry about ongoing bleeding or inadequate volume resuscitation. When you're using this as a marker of resuscitation, it's very important to be sure that the patient has not gotten any bicarb, because that will give you a false sense of security, because it will correct your base deficit while the patient still may be in a occult shock state. So here's again, I said if it's more negative than -6, we start to get worried, and you can see how the base deficit, the mortality goes up with base deficit. TEG, or thromboelastography, we're using this more and more in trauma centers. It's a whole blood test. It measures, when we get a PT or an INR that measures certain specific aspects of your coagulation function. When you get a TEG, it looks at clot initiation and lysis as well. So it looks at the net effect of all the components in your blood and how well it clots. Leave it to physicians to try to define everything in terms of adult beverage and wine glasses. But anyway, those are the different, this gives a picture like you see in the dark area on the left, how clot is formed. And those are just quick kind of measures of identifying how what clot factors are problematic. So up at the top, you see the normal, which is up at the top. So if you've got FACS, if you look as you get to the dark areas, you go from the straight line to the dark area. The straight line is longer, and then the slope of the dark area is lower. So that's from factor deficiencies. If you're on platelet blockers, you get the other view there. Fibrinolysis, where you get a quick start, but then it breaks down quickly. And then if you're hypercoagulable, you get the large picture down below. There's guides that go along with these, and these are useful measures of what specific blood products to give. So again, it's rapid. So this says it's clinician operated. It can be, and it can be done as point of care testing, at least in theory. The challenge of it, so a lot of times if you've got a busy cardiac program, the cardiac perfusionists run these. The challenge with it is, in order to keep it a verified system, it's got to get tested like every 6 hours or so. And so the problem is, if it's not tested at night, you fall out of compliance. So I've been at previous institutions where we originally used that, but because it was not always checked every 6 hours overnight, it goes back to the lab, and the lab runs it because they're available 24 hours a day. But it allows for quick monitoring. It can be used in any setting: ED, OR, angio, or ICU. It's pretty much a quick read, and it's fairly easy to interpret once you've done a few. But again, it guides specific blood component transfusion and directs what we really need to give. So let's talk about treatment for hemorrhagic shock. Again, airway, breathing, circulation. So we want to, again, just because you're bleeding from the abdomen doesn't mean we don't have to manage your airway or your breathing. In the multi-system blunt trauma patient, when a patient has been shot or stabbed multiple times, we still have to do it the same way. So ABCs is the way we begin. Is there a shock position? This is Dr. Friedrich Trendelenburg from the late 1880s. He came up with the Trendelenburg position to improve exposure to pelvic organs during pelvic exams. Somewhere after World War I, this started to be using, putting people where you get the legs is up to the ceiling and the head down to the floor, and somehow there was the misperception that this improved shock. There is no benefit in shock. So unless you're preparing to do a pelvic exam, we can probably avoid the Trendelenburg position. Having said that, let me quickly remind you from the previous lecture that the reverse Trendelenburg position, where the head is up and the legs are down, is useful in morbidly obese patients and other patients who are trying to maintain an airway and improve the airway function. So when I come into the ICU in 2022 and I see the legs, the feet up in the air and the head down below, and I ask if we're preparing for a pelvic exam, I am not being sarcastic. I am asking a medical valid question. All right, mechanical means of stopping hemorrhage. So for the pelvis I talked about later, remember 3 liters can be lost in the pelvis. So pelvic binders are a sheet. That pelvic binder you see there, we just got those binders. We switched out from the other binders, which were inadequate for a number of reasons. People will put a sheet on. I have never seen that work well because you've got to, it's not a matter of pulling, you've got to use a windlass and actually crank it tighter like you do on a tourniquet for it to actually work. The new pelvic binders we have are wider than the old version we used to have, which means that the pressure is divided over a longer, a much wider surface area. That reduces the risk of tissue damage, skin damage due to the pressure. And these are a little bit easier to put on. They're also big enough that you cut it down to size. So it comes big enough that it fits anybody and you cut it down to size. The other brands that we used to have were not big enough. And so a lot of times the big buckle in the front used to dig into your skin and cause tissue damage. But again, we put those binders on. Usually we get a before and after film to confirm that we've actually reduced the anterior opening of the pelvis and an open book fracture. Tourniquets really started coming out shortly after 2002 and 3 when we were in the wars. They work very good with extremity hemorrhage. They're all over the place now, especially if you've been to a Stop the Bleed course. So in a lot of states, every police officer, sheriff, EMS unit has a tourniquet available to use those to stop hemorrhage. Hemostatic dressings are also utilized. These look much like the 4x4s or gauze, but they've got a material in them that activates factor 7 and causes clotting and adhesion. Again, if you've been to Stop the Bleed, you'll see that some of these, it's called the Z-fold, where it just comes up, it picks up like an accordion. You can pack it into a wound if you have to, or you can lay it on top of a wound, but they're very useful in terms of helping stop hemorrhage. IV access, fastest, simplest route is best. It's the antecubital. It's not a problem to use the antecubital. It seems like in someone's teaching, they're being told that like the hand is better than the antecubital, but if you can get the antecubital, I would just go for it. Again, remember, large bore is a 14 or a 16 gauge. It's not 18 or 20. So when we look for large bore IV, we're talking about 14 or 16. Again, flow through an IV is related by the diameter or the gauge and the length. So you want a large diameter, short length catheter. The size of the thing doesn't matter. So a central catheter does not get you faster flow than a peripheral 14 or 16 gauge. The other thing is just remember with the central line catheters, they're all 20 plus centimeters long. So that means that the flow is even lower through the standard triple lumen than it would be through a peripheral. Optimally, we want to get multiple people, trying to get lines in as quickly as we can. You try to get above and below the diaphragm if we have to, and if someone's really hemorrhaging. And we want to get multiple sites if we have a major trauma, because the last thing you want to do is lose a peripheral IV and have no other access. So we tried with peripheral IVs. If we have to do a central line, we tend to go to femoral over subclavian just because it's a little bit more out of the way. frequently, we don't usually do intraosseous in the ED. Those are usually done in the field if need be. I would just give one caveat that if you have abdominal trauma, especially penetrating trauma, I would avoid the femoral. If you can, I would do up top, just because if there's a liver injury or there's bleeding from the cava or the retrohepatic veins, or any of the iliac or the cava veins from penetrating trauma, your fluid will go right into the abdomen instead of it stay in your intravascular system. Obviously, if a limb is mangled and ischemic, we want to avoid putting the IV there. We don't want to go, if we think there's a vascular wound, we don't want to go distal to that. And again, we want to strongly consider not putting a femoral line in when the injury is below the diaphragm for the reasons I just mentioned. So IV access and shock, if we have to get central access, we usually go with femoral, obviously, except if there's abdominal trauma. We try to go with the introducer, which is shorter than the standard triple lumen. If we do it down in the femoral, we're out of the way if they're trying to intubate or do a chest tube or another procedure. Subclavian or interjugular they say they're higher risk. I'm not so sure that's the case. Well, obviously, it's a higher risk of pneumothorax to do subclavian than it is to get a pneumothorax from a femoral, but otherwise, the risk is still pretty low. In chest, if you have a chest injury, place it on the side of the chest injury. So if you have a left-sided pneumothorax and you have to put a central line in, put it on the left side. Why is that? Because if you've got a pneumothorax, you're going to put a chest tube on that side anyway. So now the risk of getting a pneumothorax on that side goes away because you've already got it treated there. Osseous device, it's temporary access. You usually can do it pretty well. These are now all, I don't know that we have any manuals left, do we, Andrew? IO? Oh, okay. Anyway, you can do it manual or power. Proximal tibia, humerus are probably the best two. Sternum, if you can't avoid it, that gives us a little bit of trouble with other places that use the sternum. You obviously want to avoid fractured bones or other injury sites. You can give fluid, blood, and meds through these. Again, one of the risks is if it extravasates, you can get a compartment syndrome in that limb. So what about pre-hospital IV placement? So when I was a paramedic in the late 80s, you got 2 large bores in and you hung 2 liters of fluid. And if it took more than 8 minutes to get to the hospital, you were hanging your 2nd liters, and we gave a whole lot of crystalloid. What we don't want to do though is we don't want to sit on the scene and put those IVs in. If we put an IV in, we want to do it on the way to the hospital. What we've also identified is that large amounts of crystalloid, while it may in the short term bring up the blood pressure, it's got no ability to carry oxygen, and by increasing the pressure, you can actually increase clot disruption. So now we say if you're going to put IVs in, do them en route to the hospital. You either do a saline lock or just run a small amount of fluid in, and we try to use smaller bolus and titrate to a palpable radial artery or 80. Remember, which was a systolic blood pressure of about 80. So we want to use small boluses as opposed to pouring fluid in that they may not need. For fluid resuscitation, remember, if we give too little, they get ongoing shock, continued acidosis, myocardial dysfunction, renal failure, and death. Too much, we can actually increase bleeding by causing clot disruption and then dilute coagulation factors. So we really take a more balanced approach to fluid nowadays than we did, let's say, 15 or 20 years ago. What fluid to use? Crystalloids are relatively inexpensive and readily available. Lactated ringers is the closest to extracellular fluid physiologically, and the lactate is metabolized in the liver and kidneys to generate bicarb. Normal saline is available as well. Just remember, you'll get a hyperchloremic metabolic acidosis with normal saline. One thing that some people may think, but it's not correct, is lactated ringers will not give you a lactic acidosis. The volume of lactate in a liter of lactated ringers is not enough to do that. And it gets converted to bicarb anyway in the liver. Just remember that with both of those crystalloids, only about a third of it stays in the intravascular space, and most of that moves to the interstitial space within a short period of time. So again, when we give large volumes of fluid like we did 20 years ago, that all goes into the interstitial space and causes some cellular dysfunction, et cetera. Hypotonic fluids, all of it goes into the intravascular space. So we really don't like to use those. So just what fluids? Hypotonic fluid would be D5 or quarter normal or half normal saline, has no role in acute trauma resuscitation. Isotonic fluids, which is LR or normal saline, or which is 0.9%. That's the backbone of our crystalloid resuscitation. Now, I caveated that with crystalloid because we'll talk more about blood products in a minute. Hypertonic fluids, which would be 3% saline, 6% or 23%, are really used in very specific circumstances of traumatic brain injury. And so we don't use those primarily. We will use them in TBI. We talk about colloids. What about using albumin or gelatin solutions? There has not been any survival advantage to these products, so we don't tend to use them. They're also much more expensive than crystalloids. So that's why we try to avoid using it. It's more expensive and doesn't help. So the other thing is when you get capillary leak, the capillary leak in the capillaries is large enough to let the albumin leak out. So the quote unquote theory of oncotic pressure using albumin doesn't really bear out in patients with capillary leak. What about the starches in the dextrans? So Hespan or hetastarch. We don't really use these in the civilian environment anymore. They really don't improve outcomes. They have some trouble. They have some trouble with impairing coagulation, and so they haven't borne out. And then what about blood products? Well, traditionally we use packed cells, FFP, and platelets. I'll talk in another slide or two about whole blood, which has some advantages when a patient gets it, but logistically it becomes a little bit of a challenge with blood banks. The other thing is hemoglobin-based oxygen carriers or HBOX solutions. Used to be Polyheme, and which was made by Northfield Labs, and I think it was Hemopure by Baxter Labs. Both of those failed FDA approval and are not used. If you read the military literature, they use a lot of hypertonic saline, the hetastarches or the non-protein starches and dextrans, and they used to use the HBOX as well. Just remember, part of the issue in the military is any fluid product they bring is carried on the medic's back. So a liter of lactated ringers weighs 2.2 pounds. They're already carrying a lot of equipment. So the military's constraints were trying to bring things that didn't add a lot of weight when they carried it around, which is why they focused on some of those other products that we don't use in the civilian environment. So it's not a matter of, the civilian environment hasn't caught up to the military. There's just different constraints in the way they had to manage their patients, especially in the far forward battlefield in the way we do here in the US. So again, normal saline, 154 milliequivalents of sodium, 154 milliequivalents of chloride. If you're giving blood, it's considered the fluid of choice just because there's no calcium in it. The con of this, if you give large amounts, you'll get a hyperchloremic acidosis. And then you'll also pay for it down the road with electrolyte imbalances if you give large quantities. Lactated ringers is the fluid of choice based on the Advanced Trauma Life Support Guidelines. There's some question of whether it causes some immune modulation, although that's a little bit hard to prove in patients. It's had some indications that it does that in the lab. The one challenge with lactated ringers is because it's got calcium in it, at least in theory, if you're giving it as you're transfusing blood, it can precipitate with the chelating agents in the unit of packed red blood cells. Now, I know a number of trauma surgeons and trauma anesthesiologists who say that's probably more of a theoretical concern than not. But in general, we don't run the lactated ringers when we're giving blood products. There is a product called Plasma Light, which is basically lactated ringers without the calcium, which can also be used, and it's a little bit more balanced than normal saline. I think it's also a little bit more expensive than those, which is why we tend not to use it in large volumes. But anesthesiologists use it a fair amount in the operating room. So the small volume resuscitation, this has been a paradigm shift over the last decade or two. In the military, they used hypertonic and hyperosmotic fluids. At least in theory, some of those stayed in the vascular space longer. Again, it's got limited application in the civilian population. Head of starch, which we used to use, has got no survival advantage in trauma patients. And hypertonic saline, the 3 or 7.5%, are really for specific uses in traumatic brain injury patients. So when we look at how patients respond to fluid, rapid response patients, patients who may have been in shock, they get a little fluid, their vital signs return to normal and stay there. So the need for more IV fluid after their initial bolus is low. Sometimes we'll type across those. We try to get them, nowadays, we try to rapidly get someone assessed with CT scanning and other diagnostics to make sure that they have no injuries, and we go from there. Second category of patients are the transient responders. You give them a bolus of fluid, their blood pressures get improved, their heart rate goes down, but now over the next 15, 20, 30 minutes, their blood pressure starts to decline again. They're very likely to need more fluid. On some of those, we'll switch to blood products if we have not. I ruled out injuries, and we'll go from there. Final group is patients come in hypotensive and tachycardic and stay that way despite blood products. They've lost a lot of blood. These are class 4 shock patients. They're going to need more fluid. They're going to need a lot of blood products. These are patients we frequently go right to the massive transfusion protocol. So instead of giving the usual 2 or 3 liters of blood product of crystalloid before you go to blood products, we frequently start with blood products very early on in their resuscitation. So here's a little bit about the blood products. Obviously, red cells carry oxygen. It's also got a little plasma in it. So 1 unit of red cell should increase your hemoglobin by 1 gram per deciliter. It's stored at 4 degrees Celsius. We can give O or O negative on cross match. Takes about 20 minutes to get type specific and about an hour to get typed and crossed blood. Plasma, again, has coagulation factors. A few things to remember about this. At a non-trauma center, it takes a while to thaw, 30 minutes or more. So when someone's at a non-trauma center, we usually don't ask them to sit there and thaw plasma to give them. We try to get the patient right here, and there's some alternative things we can use. In trauma centers, sometimes this is already thawed because if we go through a large volume of this with cardiac surgery patients, ECMO patients, and trauma patients, we use quite a bit of it. And then platelets, we use pooled platelets, which is usually sometimes you'll hear it referred to as a 6-pack. A 6-pack of platelets should raise your platelet count about 50 or 60,000. Again, those are at room temperature, and so we have a marker when you get the MTP cooler. You'll see a sign to say that it's for plasma and packed cells. Platelets should not be thrown in the cooler, otherwise they're destroyed. So blood administration, the traditional or the historic way we used to do it, we give 2 liters. The blood pressure was down, we give 2 more liters. Then we give packed red blood cells. After we got to about 10 units of packed red blood cells, we check labs and then give plasma according to what your PT and INR were, and we give platelets according to what your platelet count was. That didn't turn out too well. Patients were very edematous. We now say we're going to minimize the crystalloid and go much more quickly to blood product resuscitation. And we try to go with fresh frozen plasma, platelets, and RBCs. For every 2 units of platelets, we want to give between 1 and 2 units of plasma, and the same with the platelets as well. So we try to do a 1-to-1-to-1 or a 1-to-1-to-2 ratio, and we've protocolized this with the massive transfusion protocol. This really has improved our ability to manage patients. So the old definition of MTP was 10 units within 24 hours. Now we go with 10 units within 6 hours. So component therapy on the left is what we do now. We give packed cells, plasma, and platelets, and we try to do those with the massive transfusion protocol in a balanced fashion. There's some evidence now that whole blood is better than giving the products we give. Frequently, that blood is warmed. It's not cold like it is with the packed red blood cells. Some large urban environments and large trauma centers are going to this in the urban environment because they use a lot. There are some logistical issues with the blood bank in using this. So it's not as easy as saying, let's just switch to whole blood. There's some other challenges that go along with it as well. So in blood progression, early on, when we give massive transfusion, it's uncross-matched, it's O positive or negative. Hopefully we get labs drawn real quick and we go to type specific as soon as we can. And then ultimately within, I think 45 minutes is optimistic. Usually within an hour, we try to switch to cross-matched blood. Over the MTP, we try to rapidly replace whole blood in combination with red cells, platelets, and fibrinogen. We want to reassess them on a regular basis to see how their vital signs and hemodynamics have improved. We try to keep this warm through the Belmont rapid infusion system to avoid acidosis, hypothermia, and coagulopathy. Most importantly, a lot of people, we recently in the last few years switched from the level 1 rapid infuser to the Belmont. It's really important to know how to work those, because the way you don't want to do this in the middle of needing blood to figure out how to put the Belmont together. And it's not necessarily as intuitive as one might think. So anyway, we have tubing down there. I know they do in-servicing on a regular basis in the different areas that use these. That's just an example of one of the MTPs. Every hospital has their own protocol to activate it and then to deactivate it as things move along. So what about drugs in massive transfusion? So back in the early 2000s, we used recombinant factor 7 alpha. It was called Novo-7. It was historically used for refractory bleeding and trauma. It's actually off-label for use in trauma, and it's about $8,000 a dose. There were a number of problems that occurred with this, including a significant increase in venous thromboembolic events and cardiac events. So it is no longer recommended for use in trauma patients. What about TXA or tranexamic acid? It's less expensive, which I think was some of the draw to this, is about $80 a dose. There were 2 early trials that looked at this, the CRASH trial and the MATTERS trial. Both in subgroup analysis showed an improvement if patients received it within 3 hours of being given. The problem with these studies is they were not randomized, and there was a lot of when you set up a trial to look at this, there was a lot of stuff in the trial that makes some people question the results of this. So this got used. These 2 studies made people start to use it a lot. There have been a number of other studies now that show that there's no improvement in mortality. There's mixed results whether it increases venous thromboembolic events. The Eastern Association for the Surgery of Trauma and most places now recommend that it's used as part of the massive transfusion protocol based on the TEG results that I talked about earlier with those waveforms that we showed. I realize it's still used out in the pre-hospital setting, but there's not a lot of strong evidence that is useful in terms of mortality improvement for trauma patients. PCC, we use this a lot. It replenishes the vitamin K dependent clotting factors. A number of elderly people are on Coumadin. One of the downsides is Coumadin, if you take too much or if you take antibiotics and knock off your vitamin K producing bacteria, you can get over anticoagulated or your blood gets too thin. We used to give a lot of fresh frozen plasma and vitamin K for this. Problem with giving an old person who's on Coumadin a lot of fresh frozen plasma is they can go to congestive heart failure. A prothrombin complex concentrate, or PCP, PCC, is actually, you can give it in a small volume. It has a reasonable shelf life, so you can, we can give it at some of our outside hospitals that are not trauma centers. This avoids them trying to wait at the outside hospital to thaw plasma and give it to the patient. And this works quite well in that regard. But just some recommendations. This comes from the Eastern Association for the Surgery of Trauma. So in adults with severe trauma, they recommend a organized massive transfusion protocol to reduce mortality. We do that here. In adults with severe trauma, they try to target a ratio of plasma and platelets to red blood cells as close to 1 to 1 to 1 as we can to reduce mortality. That's all part of our massive transfusion protocol. Again, as I mentioned earlier, that Novo 7 is not recommended for use anymore, and I don't know of any place in the U.S. that's still using it. When it comes to use of PXA, conditionally recommend was really weak evidence to use it, and they recommend in an in-hospital setting as a hemostatic adjunct, as opposed with TEG. So it's not recommended for the pre-hospital setting, although I understand it's still used in our protocols here. So again, we want to avoid or reduce hypothermia. Remember, I said cold kills. It impacts your coagulation factors. There's some of the other recommendations. Almost all of those we've already talked about. So some evolving concepts in hemorrhagic shock. We talk about the triad of trauma deaths. So hypothermia or cold can lead to acidosis. It decreases oxygen delivery at the tissue level. It also impacts coagulopathy. So remember, your coagulation factors are enzymes, so they work at a particular temperature, and the ideal temperature is 37 or 38 degrees Celsius, which is normal body temperature. When you get cold, like all enzymes, they stop working. And rather than having a single enzyme deficit, if you get all of your coagulation factors stop working, that's worse than just having one. So that as your temperature goes down, they can function as if there's only 10% of your coagulation factors, which is disastrous. The problem is this is not identified in the lab because you take blood out of someone who's, let's say their temperature is 92. When it goes to the lab, by the way the lab machine runs it, it warms the blood up to 37 degrees. So it's not that you don't have your factors, it's that they're not working properly in the hypothermia. So again, core temp of less than 35 degrees reduces your coagulation factor function and also makes your platelets work more poorly as well. So again, the colder someone gets, I have seen patients less than 32 degrees who have been traumatized and lived. So that's probably a little bit of an overstatement. But again, we want to keep people warm. Acidosis, again, gives you myocardial depression when it gets too low. Again, it's a reflection of the depth of shock and the degree of tissue injury. And again, that all increases your mortality, especially when your base depth is more negative than, remember I said, -6 or -7. So again, changing paradigm. We used to talk about resuscitation as we went to the ED, we went to the OR, and then the OR was a prolonged period of time. Now what we try to do is shorten our time in the ED. We don't want to spend a lot of time there because we can't definitively control hemorrhage there. The other thing we do when we get to the OR more quickly is we do an abbreviated operation called damage control, and I'll talk about that in the next meeting. But we don't stay in the OR until we fix absolutely every injury and then get them closed. We get in, we do an abbreviated procedure, we control hemorrhage, we control spillage from bowel injuries. And then if they get too cold, too acidotic, or too coagulopathic, we go to the ICU, we try to warm them up, and then we do a planned return to the operating room. So that's kind of the nature of the damage control paradigm in trauma, which is why we don't stick around in the ED much, and then we go back multiple times with some of these patients between the ICU and the OR until we get them stabilized and ultimately fixed. So again, damage control in the 90s, we got control of hemorrhage, then we tried to do all this stabilization and definitive treatment, and that's really changed. So we allow a little bit of hypotension. We don't try to get the blood pressure up to 120. We'll accept the blood pressure in the 80s and 90s. We do hemostatic resuscitation, which is the massive transfusion and balanced blood products, and then damage control surgery, which is an abbreviated procedure where we do the repair and stages. Again, we try to do restricting fluid. We don't want to, quote unquote, pop the clot by giving a lot of crystalloid that doesn't improve coagulation or anything like that. And then when we're in the operating room, we try to do an abbreviated procedure. And we titrate to mean arterial pressure, which is usually in the 50 to 60 range. So that's what I've just spoken about there. Old study. So back in the 90s, they did a study that looked at EMS with fluid or no fluid. That kind of was the move toward using less fluid in the pre-hospital setting. Almost a decade later, they did another study and they looked at ED blood pressures. And there was no difference in survival when we used 80 or 100. Now, just remember those two different studies. That was about 8 years apart, and there's a lot that changed in the way we manage patients. So you can't directly compare those two studies. But again, going up to the traditional systolic blood pressure of 100 didn't improve things. And again, what does improve things is early source control of hemorrhage, either in the operating room or in the interventional radiology suite. So they recommend target blood pressure of 80 to 90 until the major bleeding is stopped. And the caveat to this is without brain injury. So brain injured patients need a higher perfusion to perfuse the brain. The other group of patients that I think probably doesn't warrant this kind of permissive hypotension would be the pregnant patient. Geriatric patients as well. Just remember, a lot of geriatric patients have blood pressures in the 140s, 160s, 180s, and we want to, if we tolerate 80, that's a real decrease for them. So we haven't answered the question on what the ideal mean arterial pressure for both these patients is yet. So again, hemostatic resuscitation, we try to get balanced blood product resuscitation early on. Again, using cryoprecipitate as we go farther into the massive transfusion protocol algorithm. We want to minimize crystalloids as best we can, but most importantly, we want an early control of hemorrhage. So again, in summary, as we're looking for hypotensive patients, we want to assess for coagulopathy early. LR tends to be the fluid of choice, although as I mentioned earlier, if we're giving blood products, we frequently switch to normal saline as the rider. We use massive transfusion protocol early on, smaller volumes of crystalloid resuscitation. PXA is a consideration now as we use the PEG and move farther along into the algorithm. And again, we want to correct and avoid acidosis, coagulopathy, and hypothermia, and certainly stop the bleeding or getting hemorrhage control much earlier. Any questions?